Okay, so let's talk about hepatic dysfunction. We've already talked a little bit about it, but it can be, I want to just say a few little things because all of these things we're going to talk about in the different manifestations. But hepatic dysfunction can be acute or chronic, and the cause can be direct or indirect. So, by what I mean by that is that it can be something that happens acutely and then it resolves itself. Okay, so for instance, it can be from a stone in the common bile duct that's backing up and causing some hepatic dysfunction. It could be chronic, and that could be caused from cirrhosis of the liver or like hepatitis or something of that nature. So it can be a chronic disorder that may kind of wane and wave. So, you may have periods of time that they have a flare up and then they get better and then they have another flare up. Okay. Um, Direct causes are something that happens right within the liver. It's caused directly from the liver. An indirect cause is something that doesn't happen within the liver. It's caused outside of the liver. So like a gallstone, a tumor that's within that hepatobiliary system. It can be something of that nature. Okay. The manifestations that we see, jaundice is not a disease process. Jaundice is the result of something, a disruption within that hepatobiliary system. Okay. Portal hypertension is the result of the liver not functioning the way that it should, and you get congestion and backup into that portal area, which is within the liver. Okay, so we see the manifestations of that through ascites and esophageal varices. Okay, and then we can get hepatic encephalopathy. I've already talked just a little bit about, and we'll talk about it more. And then nutritional deficiencies. And remember, over here we talked about protein and we talked about the vitamins, of how that the liver plays a role in those vitamins, vitamin A, vitamin B's, and vitamin D. And so if the liver is not functioning the way that it should, then we're going to see deficiencies in protein and in those vitamins, as well as many other things. Okay, but we can see a lot of nutritional deficiencies, and as a result, these people need to have, if depending on their disease process and where they are in that spectrum of the disease process, they may need to have supplements. Okay, so they may need to have B12 injections. They may need to take supplemental vitamins. They may need to have protein supplements. So how can they get protein supplements? What's some of the ways? Do what? So like protein shakes, they can do Ensure, Boost. Now they've got the Carnation protein drink, it's like higher protein, and I drink those when I think about it, and most of the time I don't think about it, but I do eat protein bar. Now you can get so much, you can get the little protein snacks. The problem is that when we see nutritional deficits with these folks, remember over here I talked about GI, loss of appetite, nausea, vomiting. So they don't have much of an appetite. So they might need to have an appetite suppress or appetite stimulant. But if they don't have the appetite to like eat one of these little protein things that's got the nuts, the cheese, and maybe turkey or ham or something, I think about those little on the go type things, they may not be able to tolerate those things. So they may just need to have a shake, that's not going to be so hard on their digestive system, because they do have a lot of issues with the GI system. Okay, unfortunately, disruption of a lot of things. I've written jaundice up there. I'm just going to talk about jaundice. So jaundice can occur from several different things. So what are some of the, and I'm on the slide that says jaundice on it, okay? So we know that it's yellow or green tinged sclera or skin. And what happens is we obstruct that bile flow. Okay, the bile can't flow, so it's going to back up. So hemolytic jaundice, when do we see that? When it's destroying red blood cells. So we might see that in a transfusion reaction. We may see that somewhere like that. When could we see that in our smaller population? When do we see that in our pediatric population? So babies, even babies that are not even premature babies, but babies that aren't, their liver hasn't caught up with their red blood cell production, and so they have to go underneath the belly light. And then we also do the PKUs right after birth. And so why do we do those PKUs right after birth? To see if those levels are elevated, because long-term elevation can cause mental disorders. Okay, so we got to make sure that those are within normal limits. That's why it's mandated that every baby has a PKU before they go home from the hospital. Because if that's elevated and it's not treated, because they send those little cards, you stick the heel, you put it on the little paper, and you do drops on, I don't know how many different little circles that it is. I used to do it when I worked in the lab, but we stick the heel, and the heel bleeds, and it's traumatizing to me to even think about it. But we stick that heel, and then we put the blood on different circles on this card. We put the child's information, parents' information, that's sent to the state. Okay, they analyze that, and then if there's something that they see or detect that is abnormal, then they will contact the family and take it from there, and let them know that they need to do follow-ups, okay? Because that's to keep the baby, that's to detect any kind of problems that could cause mental disabilities later on, okay? So when we see that in babies, we need to, if you're going to plan to work OB, that's something that you'll have to be really in tune with. We can see hemolytic from transfusion reactions, and then we can also see hepatocellular jaundice, and that is from obstruction or from the hepatocellular, the cells within the liver being destroyed. Okay, so we can see that in several different ways. Now, hepatocellular, it can be caused from the hepatitis virus. Epstein-Barr virus can cause hepatocellular destruction. Chemicals, we've already talked about needing to know about toxins or chemicals that people are exposed to. So that's one thing that we need to be aware of, that hepatocellular dysfunction from those toxins can cause the jaundice, okay? Because we're just kind of talking about jaundice right now. Some of the other things we can see related to jaundice are loss of appetite, nausea, just generalized malaise, fatigue. Now, depending on the extent, this jaundice can be reversible. Okay, so if the disease is not extensive, then it can be reversible. Obstructive jaundice is just what it says. There's an obstruction there. That could be from an occlusion. It could be from inflammation, so cholelithiasis, which is gallstones, cholecystitis, which is inflammation of the gallbladder, or a tumor within the cystic duct, the common bile duct. The gallbladder could have a tumor, the liver could have a tumor, there could be a pancreatic tumor. All of those things can cause backup of the bilirubin, okay, and cause jaundice and itching. And what are we going to see if it's obstructive? We already talked a little bit about that. Clay-colored light stools, dark urine, itchy skin, and then increases in those labs that we already talked about, okay? I included one of the on the slide, the signs and symptoms related to hepatocellular compared to obstructed. So you all can look at that. So let's talk about portal hypertension. So we've got ascites, and somebody's done a nice job of listing ascites. And so I want to just talk about it just a little bit. So what causes ascites? Does anybody know? What's one of the predisposing things with ascites? It's right there on your slide. One of the reasons that we have problems with ascites is that they can't metabolize aldosterone, and it causes fluid retention. Okay? So our liver works with the metabolism of aldosterone, and what does aldosterone do? What does it help our bodies do? Okay? So it helps the kidneys retain and fluid and sodium, right? Sodium and water. So when we get retention of sodium and water, the intravascular fluid volume increases, okay? And that causes us to retain all that fluid. The lymphatic system is clogged as well, and so it's not helping to drain. So we get all this fluid accumulation in there. It also is related to the ability of the liver to not synthesize albumin anymore. Remember, we talked about protein and albumin. So all of those changes causes an increase in the abdominal girth, which is related to ascites. Now, on one of your slides, I've included the pathophysiology there of ascites, so you can look over that. So whoever did ascites, they wrote up here, record when you're doing your assessment. So the patient has presented, and we've done our assessment, and we're going to include an abdominal assessment in there. So we're looking at the abdominal assessment, and we determined that the patient has ascites. Okay, so we want to record the abdominal girth. We want to look and see if there's any striae or any distended veins, or there could be a hernia. I mean, there could be as much ascites, enough fluid volume accumulated to cause an umbilical hernia. We want to assess for fluid in the abdominal cavity by fluid weight or percussion, and monitor fluid and electrolyte imbalances. So we're doing our daily assessment on the patient. Of these 4 bullet points right here, what is, and you've got signs and symptoms: increased abdominal girth, increased weight, short of breath, and they definitely will be, and they'll complain of being uncomfortable. They won't want to bend over or anything like that because it causes too much shortness of breath. And then striae and distended veins. So over here, what is going to be you've got nursing interventions over here. So what's going to be your priority assessment that would go with your interventions? What would be your priority assessment and interventions out of everything that's up there? Okay, so breathing comes first before eyes and nose. So let's think that through. Okay, so they're short of breath, but are they short of breath related to their lungs, their lung function?
Well, just like you got all that fluid there in your diaphragm.
Okay, but is the fluid on the lungs?
No.
Okay, so it's not on the lungs. If they have a pleural effusion, then that's where you get into trouble. But we're just talking about the fluid on the abdomen. So let's think this through. What is our priority assessment? Their daily weight. Why is daily weight? Okay, so how much fluid are they retaining? So we want to get a daily weight, and where is it here? So you've got it under your interventions, you've got it under your assessment. So, and then you've got right here increased weight. Okay, so what are we going to be concerned about? How much of a weight gain every day? If they gain more than how much? 2 pounds. So 2 pounds. Okay, so we want to be assessing that. Now, we can assess their daily weight in a couple of different ways. We can check it by standing scale or by bed scale. So if we're going to check their weight, when do we need to check it and how do we need to check it? What are some important things? First thing in the morning. Same clothes. Same scale. If we're checking them in the bed, what do we need to do? Same linens, same number of pillows, all of those things, okay? So we've established daily weight is one of our priorities, but going hand in hand with daily weight, what else do we need to assess? Okay, but before we do eyes and O's, do what? Okay, fluid restrictions. What else? Because this should correlate with this. Okay, your abdominal girth should correlate with your daily weight. If their weight is increasing, their abdominal girth may increase as well. Okay, so you really want to monitor and check that abdominal girth and that daily weight together. Now we're going to check everything else. We're going to check their I&O and make sure that's going to be an ongoing thing that we're going to do. But every morning we want to check this and make sure that we're doing all of those things that we just said to monitor their weight. Because if they put a 2 pound weight gain on, I want to see if their abdominal girth, because is it accumulating in their abdomen, or do they have edema in their lower extremities? You know, do they have edema in the flank area? Because when we have ascites, if they lay down, where's that fluid going to go? That retroperitoneal area, so they may have bulging flanks. Okay, so you may see some bulging flanks back there. Everybody know your flanks are back here, and so you want to check that area too and make sure that they don't have bulging areas. Other things, signs and symptoms of shortness of breath. So we always get to thinking that airway is the most important, but they're not short of air because of their airway. So, you know, we always want to say, well, ABC, A is the priority, but with this patient, really and truly, that's not the most important thing, because if they're putting on weight, we've got to figure out what we can do. So we're going to come over here to our interventions and our medical management. So what can we do to decrease this and control this? So what's going to be our priority intervention, other than we do need to do daily weight and abdominal girth? So those are 2 priority interventions. But what else?
Diuretics.
Okay, so diuretics. Well, okay, so low sodium diet. So that right there, to me, that is going to combat a whole lot of things along with the diuretics. Okay? Now, what if the doctor orders Lasix for this patient? Is Lasix okay for a patient with ascites?
That's going to take a lot off at once.
Okay, so it can take a lot off at once. So what is the better choice?
HCTZ.
Okay, HCTZ might be okay. Aldactone. Right, aldactone. So we want to look at let's see. I was going to tell you something else too, and it just So let's go with aldactone. And Lasix causes you to lose a lot of sodium, okay? So if we lose a lot of sodium, then that can cause more problems with the ascites, okay? Same thing like Diamox, there's some issues with Diamox, which is another, we don't want to do HCTZ because of the blood pressure and the potassium that goes along with that. So aldactone or spironolactone, that's the other name, are the better choices for diuretics, okay? That's the better choice. So what kind of diet? We said low sodium. So what are you said you're going to educate your patient on your on the low sodium. Okay, so a DASH diet. So what are you going to tell the patient? Are you just going to say, here's you a handout on DASH diet? What do you want to tell them?
Well, avoid your salty food, your bacon.
Okay, so avoid salty foods, bacon. What else?
Salted nuts.
Salted nuts. Okay, so would you pick canned or frozen green beans? Frozen, but you still have to look at the sodium content. Yeah, like all kinds of processed foods like that, processed foods, canned meats, canned vegetables, all of those things have really, really high sodium content in them. So it's better if we encourage them not to do that. And to make better food choices like less sodium, looking at teaching them to read food labels. Teaching them to read food labels is the best thing. So if I have a patient that I'm trying to recommend a food choice to, if I wanted to recommend them a lunchtime meal, what would you recommend? Would you recommend a ham sandwich and potato chips and an orange slice? Or what about a cheeseburger and French fries and a cup of pudding? Or a turkey sandwich and some apple slices, maybe with wheat bread and no salad dressing or anything? Or what about a can of tomato soup? So what's the best food choice that they can pick? Okay, a turkey sandwich. So, because you got to think about it, even though it's processed, is that better than, is the turkey better than the canned soup or the vegetable or the ham, because ham is saltier, you've got more of a salt content there. So, a cheeseburger sounds awfully good, doesn't it? But, okay, I want you to think about something. A cheeseburger, what kind of meat is a cheeseburger? I know it's meat, but think about it. It's beef, okay? So, when you eat beef, what is the makeup of it? Okay, fat, but protein. Okay, what's the end product of protein? Ammonia. So, do you think these folks need to eat red meat? No, because even though we're talking about ascites, it can still, let me tell you, it is a very difficult process to have to learn the dietary restrictions, because you have to restrict your sodium, you have to restrict your potassium, you have to restrict your protein intake from red meat. Now you can still have protein, but you have to have some restrictions there. Let's see. So we want to provide a rationale to the patient as to why we're telling them to not eat these things.
Or sodium.
the more sodium that you eat, the more fluid that it's going to draw in, the more fluid's going to accumulate on the abdomen. Okay, so that's our rationale. Let's see. So salt poor. We can also give them salt poor albumin. Um, we want to monitor their respiratory status because they can develop pleural effusion. So you definitely want to keep that, in the back of your mind and doing a real good respiratory assessment, because if all of that fluid in the abdomen is pushing up, it can cause them to not breathe well. Let's see. Now, why do we want to keep them on bed rest?
I just figured it would be harder for them to breathe.
Okay.
Exertion.
Right, but think about this. When you're up and about, your renin-angiotensin system is triggered, and then when that is triggered, that triggers that whole domino effect, and it causes you to hold on to more fluid, okay? Because your body is wanting to not let go of fluid. So when we keep them on bed rest as much as possible to keep that down, okay? That helps to keep the fluid decreased. Then we can give them salt poor albumin. So you can give them, you can't give them like tons of albumin, but if you give them albumin, that will help to pull some of the fluid from that extravascular space back into the vascular space and help to get rid of some of that. So we can administer salt poor albumin to them to help to pull some of that in. Paracentesis, if the patient is not having a huge amount of issues with the fluid, if they're not complaining a whole lot, then we might not want to do a paracentesis on them, because you think about, we're going into a very albumin-rich area that can breed infection. You've got that protein-rich environment there. You go in there with a needle, and you can introduce microorganisms, and then you can get peritonitis. Okay, so we want to be real careful with that. The other thing that you have to be cautious about with the paracentesis is not drawing off too much fluid at a time. So you got to really monitor these folks after a paracentesis, because you don't want them to have if they've got hypovolemia from you taking too much off. You got to watch those vital signs and the signs and symptoms of hypovolemia, because even though they appear to be in fluid overload, we can put them in hypovolemia just by drawing off too much fluid, even though it's not, maybe you didn't draw off a whole lot. They're just they're real delicate. They're just really, really delicate. Okay, educate. When they go home, they need to do daily weights. They need to be monitoring their weight daily, just because of this, especially if they're not watching their sodium the way that they should. Okay, if they have more of a 2 pound a day weight gain, they need to notify their provider. Take their medicines as prescribed, and they are probably going to be on a lot of medicines. Okay, it's real important that they understand what this aldactone will do and how the aldactone works, and if they're having any signs and symptoms that need to be reported to the physician. Okay, and they need to understand how many times they need to take it a day. Okay, those are things that we need to monitor. And then monitoring their albumin, their creatinine, and their electrolytes. Because if their kidneys are not functioning the way they should, then they're not going to get rid of any of this excess fluid. Even if we pull it out, they may not get rid of it. Okay. All right. Questions about ascites? Is everybody clear? Do you have anything that you need me to clarify?
If they're ammonia size, that when you're given the lactulose.
Yes, ammonia is when we're doing that, we definitely want to give lactulose, and that's a whole different. Will you look at this and make sure you've never seen lactulose?
I didn't see it talked about in there. That's why
Okay.
I was wondering if that's something
Yeah.
we need to see.
If they have hepatic encephalopathy, That's where the lactulose comes in. Okay, so it's not really so much with the ascites, but usually if they have one, they have something else. Unfortunately, it just kind of goes hand in hand. So once they get to the place where they are exhibiting signs and symptoms, then they have to go on lactulose, and they probably will never get off of it until they either get a transplant or, unfortunately, if they pass away. That's they just, and lactulose is life altering. It is terrible, and it does not taste very good either. So, all right. So portal hypertension. One of the other manifestations are esophageal varices. So, what do we see with esophageal varices? What can we see? We cannot visualize those. So how do we know if a patient has it? That's the first thing. How can we determine?
Look at their bleeding, right?
Okay, so they may present, the first thing that they may present with is hematoemesis, okay? That may be the first thing that we see on these folks. Now, we can diagnose it with an EGD, so we can see those on EGD. If someone comes in with esophageal varices, they could have a slow leak all the way up to profuse bleeding that they could deteriorate very, very quickly if it is not handled. Now, you probably have seen, like, on some of these medical shows where that they like come in and they're like profusely throwing up blood and they have esophageal varices. And I mean, it can literally look like a slaughterhouse if they are bleeding really, really bad. If one of these varices ruptures, like, they can deteriorate and die in just a matter of minutes. Okay, if it's very much of a bleed. So you have to really be on your toes with assessment and teaching so that you do not have an issue. Okay, so signs and symptoms of shock can be one of the clinical manifestations. They come in, they're profusely vomiting blood or spitting up blood, and then it can progress to shock very, very quickly. Okay. This is often associated with alcohol abuse, and it is just one of the results of the portal hypertension. So everything within that portal system gets backed up. It's like you take a garden hose. You know, if you get a garden hose and water's supposed to be flowing through it, and you shut off the flow, what's going to happen? It's going to back up until it just explodes, or it blows off of the end of the hose or something, or the end of the faucet. So that's kind of what happens with esophageal varices. You just get congestion in all of that portal area, and it just backs all the blood up. So we often see this with people who have alcohol abuse. You know, you can see it with anybody that have any varying degrees of hepatic dysfunction, but we see it more frequently with alcohol abuse. How do we diagnose it? I've already told you, endoscopy. That will show you where the cause is. They can do a transesophageal ultrasound, where they go down with the ultrasound into the esophagus and look at that tissue. They can do CT and angiography, but most of the time we identify it with an EGD. Labs, LFTs, and CBCs. So we want to look at the liver function, look at all of those liver function tests, see if they're elevated, and if they're bleeding, then we want to look at that CBC and see what the H&H is. Okay, that would be important to see that. If the patient comes in with an esophageal variceal bleed, we've got to manage the shock. So how do we manage the shock? Rapid infusion of fluids, because we've got to get a volume replaced. So you want to do rapid fluid replacement, check their electrolytes, and replace electrolytes and blood as needed. So what can we rapidly infuse as far as blood goes? O, So there's a couple ways that they can they can stop the bleeding in the endoscopy suite. They can do sclerotherapy, so they go in and actually inject in there and stop the bleeding. They can do a balloon tamponade, so they go in there with the balloon and they open the balloon up and they wall it off. It's just like if you were putting pressure on the area. So they wall that off, and then if then they take the pressure down on the balloon, see if it's still bleeding. Things that can happen with that is you can get erosion of the esophagus if the balloon is in place for too long. Okay, usually they go in there and do sclerotherapy and they just inject some medicine in there and stop the bleeding, or they cauterize them. They can cauterize them as well. But really the only way. You're going to get volume expanders and beta blockers, vasoactive drugs, and she's written balloon tamponade over here. That is one of the ways that we can see we can manage it. As far as the nursing portion goes, if the patient has to go in for an EGD and a balloon tamponade or sclerotherapy, then you're going to do those EGD interventions. Whatever you would do for an EGD, that's what you're going to do, okay? It might be a little bit more of an emergent situation, and you might not be able to do the spraying of the throat and all of those things, okay? But as far as nursing, we want to frequently monitor them, changes in their vital signs and their LOC, monitor for aspiration, because there's large amounts of blood. They may be aspirating that blood, and then monitor for any complications. Now, when we have someone has esophageal varices, they have got liver dysfunction, any bleeding that goes into the GI system, any blood that's in that GI system, there's protein in there, right? So what does protein do? Hepatic encephalopathy, it can lead to that. So if they have bleeding, then you can see hepatic encephalopathy ensue, okay? So if somebody has a bleeding esophageal varice, they may have hepatic encephalopathy going on as well, okay? So let me look at this and make sure that there wasn't anything else I wanted to tell you. We usually see this bleeding varices with advanced disease. And like I said, it can be varying from just a little bit of bleeding, and it may show up like in the stools. If it's just a small bleed and they're not throwing up, at that point you may see it through the stools. Oh, I know what I was going to tell you all. The first thing, like if somebody comes in with a bleeding esophageal varice, you want to give them medications first, okay? So something like vasopressin would be one of the drugs that you would give, because it does not have the vasoactive properties in it that some of the other medications do. I said vasopressin, didn't I? Somatostatin is the one you want to give first because it's a vasoactive drug, but it has less of a constricting property in it. And then you might give nitroglycerin along with vasopressin. But somatostatin is your preferred drug. Let's see. Some of the things, people who have esophageal varices, once they're contained and you've got everything under control, they're going home, they need to be encouraged to not do any straining, no lifting, no pushing, pulling. They need to eat only soft foods, because you think about that delicate tissue that is in the esophageal area. If they eat things that are rough, those can cause a tear in the esophageal lining on top of that varice and cause the bleeding. So like potato chips, popcorn, anything that's rough as you swallow it, they need to avoid it. So they need to really stick with soft foods, okay, liquid and soft foods. So they may need those protein supplements as well. All right. Okay, let's see. Hepatic encephalopathy. Any questions about? So these are all the things that you can see in someone who has liver dysfunction. So hepatic encephalopathy, we usually see changes in level of consciousness, and that can be varying degrees, okay? It can be subtle changes to large changes, like, not knowing who they are, who you are, or anything of that nature. So this is encephalopathy, means something's changing in the brain, okay? This is due to the ammonia. So knowing that the patient has hepatic encephalopathy will clue you in to know that something is going on neurologically, but it's not a neurological disorder. It's just the end product of what's going on in the brain, okay? Or what's going on in the liver that's manifesting itself in the brain. So we can see subtle, so this can be slight to pronounced. Progressive confusion, just like not knowing, how to process things, how to do, basic skills, just, basic things. So their confusion can progress to not knowing who they are, where they are, what country that they're in. So you want to get that orientation status established, okay? They may have sleep pattern changes, so they normally may sleep all night, and that may go to where that they don't sleep at all. They may just literally not sleep hardly any, a couple hours at night. So they may also, you may note, this is usually, we see this as the disease progresses, and that's astraxis, and that's liver flap. So you see something in the hands, like the hands flap. Okay, you see a flap of the hands. Your book has a diagram showing that, so we can see that. Hyperactive reflexes. If you see hyperactive reflexes, they're usually end stage liver disease, and that can progress into a coma. Okay, if they go into a coma, you can give them lactulose enemas, and they'll just all of a sudden they'll be literally completely and totally out of it, and then all of a sudden they'll wake up, open their eyes, and start talking to you. It's the weirdest thing in the whole wide world. I mean, that's just how it is. My husband was getting ready to go home one day for Vanderbilt. We'd been down there for like just a couple of days, and all of a sudden he just went into a coma. Like, he's talking to us, and then the next thing we know, he's completely out of it. I mean, sternal rubs, doctor screaming at him, just could not get him to respond. I mean, he's literally laying there just like a board. I mean, he is completely, utterly like this. You have to roll him as a unit. You can't move him or anything. And he had a lot of fluid. And so we had to give him lactulose enemas. He was unconscious for 13 hours. Some people might not ever wake up. He was unconscious for 13 hours. I was asleep because I'd been up for hours. We ended up staying like 13 days that time. But he just all of a sudden woke up, started talking to my mother-in-law. I was like, they said, he just woke up. I said, like just woke up? And they said, yeah, he just woke up and started talking to us. And why is my chest so sore? They said, well, because the doctor's been like up on top of you, rubbing your chest, doing a sternal rub, and slapping him, just everything. He did not respond. So they'll just in and out. You just never know. And they can have neuromuscular disturbances too. The big thing here to determine hepatic encephalopathy are your signs and symptoms, and you can do those ammonia levels, an EEG, but most of the time they're going to have brain activity. They may not, but most of the time they have brain activity. It's just the too much ammonia has gone to the brain and it's caused them to be unconscious. Okay. Um, the big thing here is lactulose, and you need to teach the patient that they need to have loose stool. It does not need to be diarrhea. I think your book says, I can't remember how many, maybe 3 to 4 loose stools a day. Let me see. 2 to 3 soft stools a day. You don't want diarrhea because diarrhea can cause dehydration, and the dehydration will just make this worse. It'll just make the hepatic encephalopathy worse. So with the lactulose, you want 2 to 3 soft stools a day, and they will take that until, like I said, transplant or end of life. Okay. The dosing depends on the patient. They'll start out with a slow dose, and it tastes terrible. I mean, it just tastes terrible. They're going to be on some kind of antibiotics, probably, especially if they have ascites, because they want to keep that flora, the bacteria down in the abdomen. So they might be on like some kind of neomycin or some kind of medication like that, but some type of antibiotic. That lactulose can be mixed with fruit juice. It can be given by NG tube, and it can be given by enema. Okay, so any of those 3 routes. I wanted to make sure I said that. They're probably going to be on some vitamin supplements, and they may have to have glucose because of all of the changes in the body can cause them to be diabetic. Not all patients, but some of them. Our interventions. We want to provide a safe environment for the patient. If you think about having hepatic encephalopathy and all of these other things, they're kind of confused. They don't really sometimes know where they are. So we really need to have a quiet, low lit type area, okay? But it needs to be safe, clutter removed, things within reach, because we want them to stay on bed rest if they have ascites, because we don't want them, that aldosterone or renin system being triggered. Signs and symptoms of bleeding and infection. So we know what we're going to be looking for infection, right? And bleeding as well. So we're looking at our vital signs, we're looking at our daily labs, checking those H&H, checking the white count, and those things. Electrolyte disturbances, they're probably going to have all kinds of electrolyte disturbances because they're not processing things the way that they should. So their sodium may be low. They may have low potassium. That's why we have to be careful about the diuretics that we use on these folks. Feedings, they may be a candidate for a feeding tube, okay? Because as the disease progresses, it's more difficult for them to eat and to tolerate foods. Okay, they just have vomiting. Identify and correct causes. This right here is probably one of the biggest things, because if the patient gets to a debilitated state that they cannot care for themselves, the family is going to have to take over. They're going to have to make sure that they're following sodium restrictions, that they're following the protein restrictions, that they're taking their medications the way that they should, that they are, helping to monitor them for signs and symptoms of infection and bleeding. Because if they have varices, luckily we didn't have to deal with varices, but we dealt with everything else. So, it's life altering. And if it says LOC checks, I can assure you you will see subtle, teeny tiny little things that will alert you that these patients are, they're getting into trouble. If they're getting into trouble and they have hepatic encephalopathy, there could be a number of things going on. One, their ammonia level may be elevated because they've eaten too much meat. They could have bleeding going on, and that bleeding can precipitate that. They could have an infection. So, we normal flora in our colons is great and grand unless we've got some kind of disease process like this. And so just the little bit of wiggle outside of the normal can cause these folks to have hepatic encephalopathy. So you've got to have really, really good assessment skills to detect anything that is going on with them. Okay? They can be funny little characters, let me just tell you. It's funny. I mean, and you have to laugh to keep from crying. All right, questions about hepatic encephalopathy. I can tell y'all stories all day long about crazy things that my husband did. He's a mess. He's a mess anyway. He was really a mess. All right. Any questions about that chapter? Have y'all taken your pictures? I know y'all want to take pictures of these. Okay, y'all can take pictures after class then. I know y'all are going to, aren't you? Okay. So this is the next chapter. Well, let's see. Cholecystitis is first in the chapter, isn't it? If I do this, y'all are going to be all off, aren't you? I'm going to get y'all out of whack and out of order. I can't stand to do that. Like, it drives me crazy. I have to go right with the chapters. So I don't want y'all to be, even like when I'm lecturing, you got to go right with the chapter. Okay, I'm gonna just move this over here. How are we on time?
3:43.
Okay, 15 minutes. We're all right. Cholecystitis. We're okay. Cholecystitis. So I told them to just do this to where it encompasses everything, okay? Because if you've got cholecystitis or cholelithiasis, you're gonna probably have generally the same signs and symptoms, okay? So you're not gonna see a whole lot of difference. So inflammation or infection of the gallbladder or lithiasis is stones in the gallbladder, okay? So any of those can cause a disruption. If we have problems with our gallbladder, we can see that manifest in the liver or the pancreas, okay? So either of those. So when we bring the patient in, when the patient presents, wherever that they're presenting, we can see that they are probably going to have some sort of abdominal pain, right upper quadrant. They may have a rigid abdomen depending on the process and where they are in, in their disease process. If the gallbladder has perforated and bile and everything has gone out into the abdominal cavity, they could have peritonitis. But hopefully we're combating that and it's not there. But right upper quadrant pain. Why do we want to know if they've been smoking? If they have a history of smoking. Smoking, they could have narrowed ducts, because remember everything clamps down whenever we smoke. Their nutritional status. Have they had nausea, vomiting, anorexia, or anything like that? And if so, has it precipitated with meals? Okay, so we want to know if it occurs with meals. What kind of meals are they taking? And let's see, do they have that on there? Diabetes and obesity, that can be a big thing because they don't process the fats the way that they should, that they're eating in their diet, and that can cause some sluggishness in that gallbladder, okay? And if it's sluggish, then everything sitting there can cause an infection, all right? And a history of opioid use. So those things can all need to be assessed and found out if any of these things are predisposing factors. Now, if the patient, let's see, this is post-procedure. So let's go to signs and symptoms. So they're going to come in pain and tenderness, we already said, nausea, vomiting. Now, their pain could radiate. So that pain is in the right side, but it could radiate into the shoulder area. It could radiate all into the abdominal area. And they could have a fever, okay, if they have got inflammation there and infection. So they put over here fever above 100, 100 or 100.3, 101, depends on the doctor, okay? They determine whether or not. So 100.3 is generally what we look at. So if somebody comes in, this is pretty cut and dry. If somebody comes in and they've got gallbladder disease, what are we going to do for them?
Take it out.
We're going to take it out. Very rarely does anybody say, well, I'll just suffer through it, unless they're a nursing student and they're trying to get through nursing school, or they're nursing faculty and they're trying to get through the semester. Most everybody's like, okay, when can you schedule me? Because sometimes they've had recurrent episodes, and those recurrent episodes just continue on, and they're like, okay, finally I'm to the place, I've got to get it out. So if they're going to get this out, well, they put medical management, so we can try to do a low-fat diet at first, and if the low-fat diet doesn't work, then we're going to have to probably have it out, because we're just going to keep on. So when I say low-fat diet, what do we want? What do we want to tell them not to eat?
Red meats.
Right, no butter, we don't want like real high fatty meats. Anything that's got a high fat content in it, we want to avoid that. So if we're just trying to manage it medically and not have to go to surgery. So if we need to go to surgery, then we're going to have to do all those pre-things, okay? So if we're looking at diagnostics prior to surgery, we're going to look at a CBC, and what's that going to tell us in relation to this disease? If they've got infection. We can also look at their H&H to see if they're bleeding or anything, okay? We can look at their vitamin levels, and why do we want to look at that? And their PT and INR. Because if there is a stone, or if it's inflamed, that's shutting off that biliary duct and the hepatic duct. If there's something going on there, then nothing can get through, and we can see alterations in the vitamins and the INRs, PT and INR. So the best way to diagnose this is by ultrasound. Ultrasound is the best way. Do they have to have any special considerations for ultrasound? So what do we say? NPO for a few hours. They're going to have a HIDA scan. Then they're going to get some dye, and they'll have to have an IV. But radiology will do that. So, and they will know if they're supposed to do a HIDA scan or not. Okay. If there is a stone in there, they can go in and do a cholecystectomy to see if there's a stone in there. And they can get the stone out by ERCP. And there's a video on Blackboard for an ERCP, and that's basically a side port scope. So there's a scope with a camera on the side of it. They can get down into that common bile duct and see if there's any stones in there. And they can retrieve those stones a lot of times with those ERCPs. Now that can throw a patient into pancreatitis, but it's rare, but it can happen. The ERCP, same thing as a scope. Same prep, same everything, okay? Um, Education. So if the patient goes and has the gallbladder out, hopefully they can do it laparoscopically. 4 incisions on the abdomen. So post-procedure, they're gonna need to know wound care. So what kind of wound care are they gonna do? Depends on the doctor, but usually it's showering the next day and taking the dressing off in a couple of days after that. Avoid high-fat diet. So they definitely want to avoid a high-fat diet. No alcohol or smoking afterwards, because alcohol can just cause some issues with pain medications, and smoking is just bad. They're both just bad for you. Why do we want to avoid NSAIDs after procedure?
Bleeding.
Avoid NSAIDs.
Risk for bleeding.
Increased risk for bleeding. Increased risk for bleeding. Take all of your antibiotics. Watch for signs and symptoms of infection. No heavy lifting. Follow-up appointments, and call the surgeon if there's any increase in temperature. Let me see if there was anything I was going to tell you all. I think you all covered all of it. Oh, with an ERCP, they do get some moderate sedation. And, okay. So let's talk about diet with these. So you said low fat or high fat. So what do you want to avoid? And what do you want to recommend? So let's do a diet teaching plan. Y'all always hate diets. Y'all hate diet teaching. Everybody wants to be on a diet, but nobody wants to teach on diets. So what do you want to have the patient, what can you have them to do? Low fat. So if it's low fat, it's gonna be high what? So higher protein. So what do we want to, do we want them to eat fried foods? Do we want them to, so maybe eggs, but sometimes eggs can be hard to digest, even though I know it's high protein.
She said baked food.
Oh, baked food. I thought she said eggs. I was like, eggs.
I was like, what?
I do that to my mother all the time. I'll say something, she'll think I said something totally opposite, and I'm like, what? So what about cheeses? Do we want them to have cheese? Probably not. Okay. So we could suggest things like mashed potatoes, fruits, vegetables that are non-gas forming vegetables, because especially right after a gallbladder surgery, they're gonna have a lot of gas, and that can cause them to have like chest pain type feelings. Okay. All right. So if we're trying to avoid those things, make sure that that you're educating and telling the patients, what they do and don't need to do. On your slides, I put like the nursing process there for a gallbladder surgery, for cholecystectomy, for cholelithiasis, and so you all can look through all of those. What time is it? Okay, it's 5 minutes till time to leave. If anybody wants to go ahead and go, that's fine. I'm gonna finish up the recording, and then I'll just post it all together. So you all are free to leave, and then I'll just finish the recording at the end, okay?
Will it be uploaded tonight?
Yes, I will upload it before I leave.